39-year-old male come with pus discharge perineal region, perineal pain prior to time of fistula surgery. Resting pressure has been on a higher side and squeeze pressure is normal. Induration at 12 o'clock. External opening, 3 external opening at 11 to 12 o'clock has been observed. As for the fistula mapping, there is internal opening at 12 o'clock. There is intersphincteric tract, high transphincteric tract, and perineum space. There is a tract with one external opening at 12 o'clock, another end at 12 o'clock, and third is at 11 o'clock. So it becomes anterior high transphincteric fistula. We do usually all fistula in prone position, particularly when there is a complex fistula. Prone position is very good. On MRI, we felt there is internal opening at 12 o'clock, but clinically also there was an internal opening at 12 o'clock. But on table, we are trying to flush normal saline. We usually use normal saline. Normal saline is not coming from internal opening, but we can appreciate that there is a tract going in the 12 o'clock position. So in prone position, it's very good way to find out the disease and think of a gentle probing. We try to do it. In spite of probing, we are not able to reach the internal opening. Intersphincteric space we can reach, but internal opening we couldn't reach. So possibly we are having internal opening at 12 o'clock. That's clear. Unnecessarily we don't want to make a fresh internal opening. As per clinical induration, we can feel at the dentate there is indurated space. In even whatever we are going to do procedure, we usually prefer going intersphincteric space. What actually digged in lift position, we usually go in intersphincteric space and tackle the intersphincteric space properly. So on the both side we are hooking the tract. We can appreciate that although internal opening has been not identified on table by flushing or using the probing, but we can get once we hooked off the fibrotic tissue, and we are able to appreciate that thick fibrotic tract which is there, which is the culprit of the whole disease, has been tackled nicely. We are doing as good as proximal intersphincteric fistulectomy, that what we do in Piltech procedure, and we have divided that internal sphincter and mucosa, submucosa proximal to the internal opening. So this is part of Piltech has been done. We just wanted a distal part also to clear. Distally there were 3 to 4 in external opening. All external opening we want to take out from external opening till the external sphincter. We are taking out completely. We are getting from external opening. Slow and gentle dissection is a key in any case. We are proceeding the dissection around the fistulous tract. Here we have to take out all disease component, and we should make sure that we are not taking a normal tissue. Normal tissue is left behind, disease component is dissected and taken out. All the external opening has been now lifted up. Slow and gentle dissection we are getting done, and we are progressing near the external sphincter. We can appreciate now we are settled at the level of external sphincter. Considering 3-time recurrent disease, here we plan to do complete fistulectomy so that we will remove all the disease and do the primary sphincter repair. So disease has been taken out. We can nicely appreciate a normal muscle tissue has been left behind and complete disease component has been getting excised. In fistula, it is always very important that disease component at the internal opening has to be taken out. Even if we are doing fistulectomy, it is better to take out complete disease. This is the complete fistulous tract we have opened up. We can appreciate there is a mucosa, submucosa, internal sphincter, there is external sphincter, there is external sphincter, there is external sphincter, external sphincter. We can appreciate completely, and once we can see that this is the deep perineum space and perineum membrane has been opened. We usually do intersphincteric space buzzing even in anything, lift, will take or primary fistulectomy. We try to buzz the intersphincteric space, which is the culprit. For doing the primary sphincter repair, we usually take stitches from outside to in, so that knot will lie outside, which will be comfortable for the patient. What happens is the knot till it get dissolved, patient will feel the uncomfort. We take a 2-3 stitches and threads are going from out to in and coming out, and once we put knot, all the knot will be lying outside, not inside. So we can pre-place the stitches first. Now we can appreciate all the 3 separate threads, and one by one we can tie the knots. So benefit is as good as this is a routine primary sphincter repair only, but when you take a knot outside, patient will not feel unnecessarily. We can see that the scope is not able to put, so good, we need to put some resistance. Good repair of external sphincter has happened, and we are taking 1 or 2 stitch at the level of internal sphincter and the mucosa with vicryl, so that also will approximate. The intent is to reduce the size of the wound, and we have taken, and we will keep external opening as saucer kind of thing. It will help to heal nicely. Patient has a good recovery and complete wound healed by a 4th week. We are taking 2 stitches at the deep perineum space to approximate the space. During this, when we are taking primary sphincter, after pre-placing the stitches, we release the lateral stretch. We can see that narrow shallow wound. Thank you for watching this video. Thanks.